content, and also Iris company for holding the platform, and Dr. Iman Fikri, professor in Azad University, for helping me. This activity is a peculiar and pioneer activity by our society, the Egyptian Society of Clinical Rheumatology and Immunology, the EGYSIR, currently headed by Professor Muhammad Salah, senior professor in Ain Shams, and he honored us with a very unique presentation in one of those entities, and he is a great supporter of the society and the school. Our society is a very unique one. It has been more than 10 years with very dense presentation from Egyptian universities and armed forces hospitals. And it's the only one with so many satellite school affiliated to it. Our school is the Musculoskeletal Ultrasonography School, and there is also the Immunology School and the Metabolic Bone Disease School. So I thank you very much, our current President, Dr. Muhammad Salah. Also, I would like to say that tonight I will be pleased to present Professor Ghaffar Ragab. He's also a major co-founder, a board member, and the first president of the Egyptian Society of Clinical Immunology and Rheumatology. And I will be presenting his biography soon. Currently, I would like to share the flow map of our activities. So I hope if you can confirm, you can see. This was the first plan for the induction course presented by the society. Our society has a live meeting every 3 months and is still active despite the COVID and so many scientific activities. So this was a peculiar one, to do 3 episodes by international speakers on some very, very important rheumatological subjects. First to be discussed by senior professor in rheumatology, and then presented by ultrasound, complementary to the same subject, by international faculty. This was the first episode by Professor Muhammad Salah and Carlos Acebes about the psoriatic arthritis. And then I was supposed to present with Professor Ghaffar Ragab the second one, which was delayed to tonight because of my circumstances. This was the last episode we had on January 28 by Dr. Basil Al-Masri, who is now president of the RLAR. And by the way, the RLAR program is currently holding, and he is sending greetings to the board committee and apologizes for attendance for being busy heading the RLAR. And Professor Nemanja Demaniov from Serbia is the secretary of the EULAR about the rheumatoid arthritis and the early differentiation with osteoarthritis. Tonight, we will be presenting about gout. And honestly, I have the honor to put my name and picture beside my professor, Professor Ghaffar Ragab. And I'm sorry about the new date, which was a little bit delayed. So let me first introduce Professor Ghaffar Ragab. He is a full professor of internal medicine and rheumatology since 1995. He's Cairo University graduate at year 76, and he has master's degree at 1980 and MD degree 85 from Cairo University. And then he moved to the United States for training in Boston University in 1983. Also going back again at sabbatical year, postdoctoral at the University of Alabama at Birmingham, Department of Clinical Immunology and Rheumatology as a Peace Fellow. And he submitted early work in the American College of Rheumatology on interleukin-7 on murine lymphocytes. He headed the Clinical Immunology and Rheumatology unit affiliated to the Internal Medicine Department in Cairo University. He established the specialty there, and he offered so many help in putting a very advanced department with full equipped and also specialized clinics. He's a professional member in the American College of Rheumatology, an international fellow member. He is also a member of the International Study Group on Extrahepatic Manifestations of HCV. He's a member of the French Group for Vasculitis Studies. Internationally, he is a regional coordinator of AIDA, the Autoimmune Inflammatory Disease Alliance, and a co-founder of IMAC, the Aortic Disease Consortium, and a member of the editorial board of the Journal of Advanced Research. This is a multidisciplinary journal of Cairo University, which has a recent impact factor of 6.9, and it is held by Elsevier, and he's the associate editor for medicine since 2013 till 2020. Professor Rajab contributed 2 books with Springer as a chief editor, the Microbiome in Rheumatic Disease Infection, and the Precision Anticoagulation Medicine, truly astonishing books. But he also contributed 8 books, chapters to textbooks published by international publishing, including by Oxford University and Springer and Elsevier. He was awarded also so many awards: Cairo University Book Fair Prize at year 2000, and he won the Country Book Fair Prize for Best Cultural Work and book about physics and philosophy. This is granted by the country president at year 2000. كتاب الفيزياء والفلسفة كأفضل عمل ثقافي وكتاب لعام 2000. He also won Cairo University Prize for Medical Genetics in 2016, and he was also honored in 2019 as a Faculty of Medicine Award. Dr. Ghaffar is also interested, for those who don't know, in history, philosophy, international music, and so many things extracurricular. And he performs very well as much as the medicine on those subjects. He is a reviewer of the British Medical Journal, Annals of the International Medicine Journal, Human Immunology, Journal of Clinical Rheumatology, International and Emergency Medical Journal, Clinical Rheumatology, Journal of Clinical Case Reports, Clinical Science Journal, Journal of Hematology and Thromboembolic Disease, Springer, Nature, and Macmillan International Publishing. He co-authored more than 50 articles with total citations of more than 600 or 700 citations. Most importantly, today it's related, a paper which is a reference paper about gout and all disease in new perspective, a review study. And it alone, it has more than 220 something citation till now. And it is recommended by the Royal College of Physicians as a sort of study for the topic. So we are really honored today to have him speaking about gout. And I thank him very, very much for his support throughout our activities. And the floor is yours, Professor Rajab, please.
Okay. First of all, thank you for inviting me to attend this, to do this presentation. It's really a great pleasure for me to join this with Dr. Adham, a well-known figure, a world-renowned figure in musculoskeletal ultrasound. For those who do not know, Adham shared a long history with me as in my assistant in the clinic. And he was a pioneer in working on musculoskeletal disease ultrasonography since early 2000. And he was behind the idea of inviting the Spanish School for Musculoskeletal Ultrasonography for a workshop in Cairo in the year 2010, which paved the way for many others to be interested in this field. And I know that he's a trainer and in this regard. Regarding my paper, courtesy of him, he supplied me with valuable images for the paper in this paper for the musculoskeletal ultrasound of gouty arthritis. And he's actually a long-term or a lifelong friend till now, and I consider him like a son to me. So I'm pleased to do this, but at the same time, I have been the third in a line after 2 wonderful presentations by my colleagues and friends, the previous people who presented their talks on other topics, which makes it all the most difficult for me to impress with what I'm going to say. So forgive me for any shortcoming. I hope it is not. Also, being late, I know that Adam went through some tough period, and I'm glad that he's back to activity again. And I'm honored by his presentation. So thank you very much. I also thank the company Amgen for hosting and supporting this meeting without interfering in its scientific content. Iris company for all the good preparations, and EGYSIR with its president, Dr. Salah, for supporting all these scientific activities. And I'm willing to start now. Actually, I will not present a paper, a comprehensive paper or a compendium on the topic. I'm just going to spotlight some points where I will concentrate on some background knowledge on gout and hyperuricemia, and then I will concentrate on or focus on the diagnostics, and finally on the management guidelines by the ACR for the year 2020. Let us start now. Gout. I will rely in my background on the papers that Dr. Adam gave a hint about. It's gout and all disease in new perspective. I'm using it as a reference for most of what I'm going to speak of in the presentation in the beginning as a background. This paper was combined contribution from Professor Thomas Bardin, a well-known figure in gout all over the world, my young colleague, Dr. Mohsen Shahali from Suez Canal University, and myself. First, we start by definitions. Hyperuricemia, we mean by hyperuricemia is a pathological threshold when the pathological threshold of hyperuricemia is defined as 6.8 milligram per deciliter. That's when it exceeds this limit. Gout is a systemic disease that results from the deposition of monosodium urate crystals in tissues. Increased serum uric acid above a specific threshold is a requirement for the formation of uric acid crystals. Despite the fact that hyperuricemia is the main pathogenic defect in gout, many people with hyperuricemia do not develop gout or even form uric acid crystals. In fact, only 5% of people with hyperuricemia above 9 milligram per deciliter develop gout. Let us bear in mind this figure to avoid unnecessary trials to reduce hyperuricemia when it is not necessary. It's all a matter of risk and benefit. Excuse me. The general prevalence of gout is 1 to 4% of the general population. In Western countries, it occurs in 3 to 6% in men and 1 to 2% in women. In some countries, prevalence may increase up to 10%. Prevalence rises up to 10% in men and 6% in women more than 80 years old, which is significant. Annual incidence of gout is 2.68 per 1,000 persons. It occurs in men 2 to 6 folds more than women. Worldwide, incidence of gout increases gradually due to poor dietary habits and increased incidence of metabolic syndrome, obesity, lack of exercise, and fast food, relying on fast food. The pathogenesis of hyperuricemia can be divided into two main causes: overproduction of uric acid by diet or the endogenous production, or the decreased excretion of uric acid in urine. This is a figure which shows, which simplifies the causes of hyperuricemia, whether it is due to overproduction, which accounts for 10% only, or the underexcretion, which accounts for 90% of the causes of hyperuricemia. The pathogenesis of acute gouty arthritis is provoked or triggered by the deposition of the crystals in the joint, which invites monocytes and neutrophils and complement activation, causing chemotaxis and the production of a multitude of lymphokines and other mediators, ending in tissue injury and inflammation. This is the pathogenesis of acute gouty arthritis. In chronic gout, the pathogenesis results from chronic inflammation that follows recurrent attacks of gout. Chronic gout manifests by chronic synovitis, bony erosions, cartilage damage, and tophi formation. I'm sorry, there is a missing F here. This can be explained by different mechanisms. The presence of urate crystals in the synovium leads to stimulation of chondrocytes to produce inflammatory cytokines, nitric acid, and matrix metalloproteases, resulting in cartilage damage. Also, on the bone level, there is a contribution due to the activation of the rank and rancle. Gouty erosions are characterized by having overhanging edges and partial preservation of joint space. Furthermore, osteoblasts can release pro-inflammatory cytokines, leading to erosions and bone destruction, in addition to compromising their own bone formation function. However, we do not consider uric acid as totally harmful. Although hyperuricemia is the main cause of gout, uric acid itself is an antioxidant that has a protective role on vascular endothelium. So the presence of uric acid is essential for vascular integrity and homeostasis of human body's functions. On the other hand, some studies found that allopurinol xanthine oxidase inhibitor used for treatment of hyperuricemia and gout has protective effects on vascular endothelial cells, reducing cardiovascular risk. What determines whether the presence of uric acid is beneficial or not is the type of tissue affected, whether it is intracellular and whether it is intracellular, extracellular, and its concentration. This slide was added to address a very complicated point when we have what used to be called the tumescent gout, where we have gouty arthritis on top of rheumatoid arthritis or in combination of it. It was noted that when we act tough in reducing uric acid, it may not cause amelioration of the arthritis. It paradoxically cause increase in the activity of arthritis and severity. The diagnosis of gout passes through 4 stages or encompasses 4 phases: asymptomatic hyperuricemia, number 2, acute gouty attack, number 3, intercritical period, number 4, the chronic tophaceous gout, destruction of joints with formation of palpable tophi. Let us go to the 2018 updated European League Against Rheumatism evidence-based recommendations for the diagnosis of gout. The recommendations focus on some overreaching goals, and these were discussed in the following points as recommendations. Search for crystals in synovial fluid or tophus aspirates is recommended in every person with suspected gout because demonstration of monosodium urate crystals allows a definitive diagnosis of gout. Number 2, gout should be considered in the diagnosis of any acute arthritis in an adult. When synovial fluids analysis is not feasible, the clinical diagnosis of gout is supported by the following suggestive features: monoarticular involvement of a foot, especially the first MTP or ankle joint, previous similar acute arthritis episodes, rapid onset of severe pain and swelling at its worst within 24 hours or less than 24 hours actually, erythema, male gender associated cardiovascular disease, and hyperuricemia. These features are highly suggestive but not specific for gout. It is number 3, it is strongly recommended that synovial fluid aspiration and examination for crystals is undertaken in any patient with undiagnosed inflammatory arthritis. Number 4, the diagnosis of gout should not be made on the presence of hyperuricemia alone. As we said before in during our talk on hyperuricemia. Number 5, when a clinical diagnosis of gout is uncertain and crystal identification is not possible, Patients should be investigated by imaging to search for monosodium urate crystal deposition and features of any alternative diagnosis. Number 6, the plain radiographs are indicated to search for imaging evidence of monosodium urate crystal deposition, but they have limited value for the diagnosis of gout flare. Ultrasound scanning can be more helpful in establishing a diagnosis in patients with suspected gout flare or chronic gouty arthritis by detection of tophi not evident on clinical exam, or a double contour sign at cartilage surfaces, which is highly specific for urate deposits in joints. This point focuses on imaging, and I will give it more attention during our presentation. Number 7, risk factors for chronic hyperuricemia should be searched for in every person with gout, specifically chronic kidney disease, overweight, medications including diuretics, low-dose aspirin, cyclosporin, tacrolimus, consumption of excess alcohol, particularly beer and spirits, non-diet sodas, meat and shellfish. Number 8, systematic assessment for the presence of associated comorbidities in people with gout is recommended, including obesity, renal impairment, hypertension, ischemic heart disease, heart failure, diabetes, and dyslipidemia. These are the 8 recommendations. Let us go to diagnosis. Diagnosis will rely after the clinical exam definitely on laboratory diagnosis and imaging modalities. The gold standard of diagnosis for the lab is the identification of monosodium urate crystals, which is the gold standard and the definitive diagnosis. In synovial fluid, aspirate using polarized light microscopy. Further analysis of synovial fluid should include leukocytic count, chemistry, culture, and sensitivity, because it needs to be differentiated from infection and other pathologies. In acute gout, synovial fluid leukocytic count may exceed 50,000 cells per milliliter in some cases, mostly polymorphed. Chemistry reveals normal glucose levels, contrary to septic arthritis, in which bacteria consume glucose, leading to low levels. Care should be taken to exclude septic arthritis in gouty cases, as both may be present in the same joint. So, culture and sensitivity along with gram stain is crucial to confirm the diagnosis and exclude infection or septic arthritis. Analysis of amount of uric acid in urine over 24 hours is useful in assessing the etiology of hyperuricemia in gout patients. Urinary uric acid of more than 800 milligrams per 24 hours indicates that such patients have increased production of uric acid. Thus, they excrete a large amount of uric acid. They require a drug that prevents uric acid production, such as xanthine oxidase inhibitors, rather than a uricosuric agent. This statement will find some counterpoint for it in the recommendations by the ACR. They don't recommend strongly to do this before choosing the medication, because they believe that the sample collection, the 24-hour collection or otherwise, and the diet will influence the result and may interfere in the choice of the drug when we have higher rates. So they give a recommendation which does not support this idea. So we'll get to it when we start reading the recommendations or going through the recommendations of the ACR. Renal function tests should be done regularly for such patients due to the high risk for stone formation, those who are excretors. We now arrive at the radiological diagnosis, which focuses on the imaging in gout, which is the center of attention of our series of lectures. I will start by other modalities besides the ultrasound, and then I will leave the part of the musculoskeletal ultrasound to Dr. Adam Abou Ftouh to discuss and demonstrate. Number 1, we start by conventional radiography. Radiographic changes may be missed for a minimum of 10 years after the first gouty attack. In chronic tophaceous gout, the main radiographic features are tophi, which are articular or periarticular soft tissue dense nodules. Monosodium urate deposits in the cartilaginous part, joint space narrowing in advanced disease. Bone erosions are characteristic. They are well circumscribed, intra-articular or juxta-articular lesions with overhanging margins. They result from the growth of tophi into the bone, hence they are usually seen near tophi. Periarticular osteopenia is usually absent, which is a point to distinguish it from RA, and proliferating bone can be seen mostly as irregular spicules. Calcified monosodium urate deposits can penetrate in the bone. In severe cases, they should not be confused with bone infarcts or enchondromas. Radiography has low sensitivity, 31%. However, its specificity is high, up to 93%. These are pictures to show what we're talking about on the erosions, the space, and the overhanging edges. This X-ray is borrowed from the archives of the ULAR for teaching purposes. This is the famous podagra, or the great toe demonstrates, where the great toe demonstrate extensive juxta-articular erosions with soft tissue swelling and little osteoporosis. Although here it's very extensive. We used in the past to say that gout is among the group of disease showing on the X-ray a lumpy, bumpy appearance. By lumpy, we mean the swelling that we have here, and by bumps, we are talking of the erosions or this damage done to the bone. And the differential diagnosis includes, but here it is obviously we are talking of gout. The lumpy, bumpy differential diagnosis for differential diagnosis includes rheumatoid arthritis, sarcoidosis, amyloidosis, and gout, as we mentioned, and multicentric reticulohistiocytosis, the old name for the histiocytic group. The ultrasound, I will just skip this. In gout, the features can be divided into specific and non-specific findings, and I will not elaborate on this. I leave it all to Dr. Adam to talk about. The specific features, the double contour sign. This picture was actually borrowed from Dr. Adam Abul Futuh, and then the tophi and aggregates. These are clinical picture of gout from one of our patients, or more than one. To the left side, we have tophaceous gout with deformities and the huge tophus over the third MCP of the right hand. And then we see both hands together. And then there is the ankle showing many tophi around the joint, and then the famous site for gout, which is the greater toe. Intra-articular tophus in the metatarsophalangeal joints, and again, this was courtesy from Dr. Adam Abul Futuh. The conventional CT. CT is characterized by excellent resolution and a high contrast. Hence, it is the best technique for the assessment and characterization of crystal arthropathies. Conventional CT is not helpful in the diagnosis of acute gout, as it cannot detect inflammation, synovitis, tenocynovitis, and osteitis. However, in chronic gout, it is able to detect erosions better than magnetic resonance imaging or conventional radiography. These are described as well-defined, punched-out lytic bone lesions with sclerotic overhanging edges. The specificity of CCT for the assessment of tophi exceeds that of ultrasound or MRI. CCT can help to monitor disease burden and response to therapy, but has the disadvantage of radiation exposure. The dual energy CT, the introduction of this new imaging technique opened a new horizon. It allows the differentiation of deposits based on their different X-ray spectra. It applies the concept that the attenuation of tissues depends on their density, atomic number, as well as the photon beam energy. Like CCT, it can detect damage, but does not help in inflammation. It is superior to all other available imaging technologies in its ability to identify polyurate deposition in the area imaged. This is an example of a dual energy CT or DECT of a gouty patient showing two views of MSU deposits in red in the tibialis posterior tendon. And again, this photo or this DECT example is courtesy of Dr. Thomas Bardam, Professor Thomas Bardam. DECT can offer a quick, non-invasive method to visualize MSU crystals, soft tissue changes, and early erosions at high resolution, even before CR. This particularly helps in the differential diagnosis from pigmented villonodular synovitis, psoriasis, and septic arthritis, which can share some clinical features with gout. DECT is highly accurate in detecting MSU crystals in joints, tendons, ligaments, and soft tissues, and can be used to identify subclinical gout with high specificity. It, however, misses crystal deposition on the surface of cartilage, which is a feature ultrasound can detect at the GCS. There are many causes of false negatives. Lower density of tophi due to lower crystal concentration, small size of tophi or crystals less than 2 millimeters, or technical parameters. On the other hand, false positive results were described around nail beds, in the skin, in regions of metal artifacts, and in severe OA. DECT is not widely available, which limits its application for clinical and research purposes. Its costs are equivalent or higher than CCT, and it entails as radiation exposure. The MRI features, now we go to the MRI. Its features of arthritis are those of non-specific inflammation, synovial thickening, effusion, erosion, and bone marrow edema. Tophi show homogeneous T1 signal intensity, low to intermediate, and heterogeneous T2 signal intensity, variable, low to intermediate. MRI role is limited because of expense and limited availability. It is, however, useful for evaluation of gout at unusual sites. The literature abounds with case reports in the axial skeleton for presentation as spondyloarthritis, carpal tunnel syndrome, crown dense syndrome, paraspinal abscess, or intra-abdominal mass. The nuclear scintigraphy is rarely used for evaluation. Positive results are often found incidentally when a study is performed for other indications. I'm sorry for the extra bullets. Positron emission tomography or the PET scan case reports in gout showed articular and periarticular FDG, 18 uptake, soft tissue FDG uptake, identifying tophi has also been reported. This can be helpful when gout presents at unusual locations. Now we go to the final, or the third part of our presentation, which spotlights the 2020 American College of Rheumatology guidelines for the management of gout based on the GRADE approach or methodology. Number one, we can go back to, whoever wants to go back to the original paper published simultaneously in arthritis care and arthritis and rheumatology for more details and the degree or the level of evidence and so forth. Number one, the first group discusses the indications for pharmacologic urate lowering therapy, ULT. For patients with one or more subcutaneous tophi, we strongly recommend initiating ULT over no ULT. Number two, for patients with radiographic damage, any modality attributable to gout, we strongly recommend initiating ULT over no ULT. Number three, for patients with frequent gout flares with more than 2 per year, we strongly recommend initiating ULT over no ULT. Number four, for patients who have previously experienced more than one flare, but have infrequent flares currently, less than 2 per year, we conditionally recommend initiating ULT over no ULT. Meaning that special circumstances should be taken into consideration. Number five, for patients experiencing their first flare, we conditionally recommend against initiating ULT over no ULT, with the following exceptions. For patients experiencing their first flare and chronic kidney disease, stage 3, more than 3, serum uric acid more than 9 milligram per deciliter or urolysis, we conditionally recommend initiating ULT. Number 6, for patients with asymptomatic hyperuricemia, that is uric acid above 6.8 milligram per deciliter with no prior gout flares or subcutaneous tophi, we conditionally recommend against initiating any pharmacologic ULT, allopurinol, buxostat, probenecid over initiation of pharmacologic ULT. The second group deals with recommendations for the choice of initial rate lowering therapy in patients with gout. Number 1, for patients starting any ULT, we strongly recommend allopurinol over all other ULT as the preferred first-line agent for all patients, including in those with chronic kidney disease, stage more than 3. I will get to this point again. Number 2, we strongly recommend the xanthine oxidase inhibitor over probenecid for those with CKD, stage more than 3. Number 3, for allopurinol and febuxostat, we strongly recommend starting at a low dose with subsequent dose titration to target over starting at a higher dose, that is less than 100 milligram per day and lower in patients with chronic kidney disease for allopurinol or less than 40 milligram per day for febuxostat. Number 4, for probenecid, we conditionally recommend starting at a low dose 500 milligram once or twice daily with dose titration over starting at a higher dose to avoid the side effects or in all this group. Let us go back to our first point. This was based on a paper published in the New England Journal of Medicine showing that there were mortalities with febuxostat, with cardiovascular disease related mortality more than the allopurinol. But the study, when read in depth, it shows that the patient there was no control group, and to have the exact figure for the risk or the hazard ratio of febuxostat, and the patients who were on febuxostat have already stopped their medication, so it cannot be ascertained. And recently there was a recent paper in the Lancet which opposes this opinion as regards the risk of febuxostat. But we'll get to the point where the ACR gave its advice regarding the presence of cardiovascular disease. Number 5, we strongly recommend initiating concomitant anti-inflammatory prophylaxis therapy, colchicine, NSAID, prednisone or prednisolone over no anti-inflammatory prophylaxis. Number 6, the choice of specific anti-inflammatory prophylaxis should be based upon patient factors. Number 7, we strongly recommend continuing prophylaxis for 3 to 6 months rather than less than 3 months, with ongoing evaluation and continued prophylaxis as needed if the patient continues to experience flares. Number 8, when the decision is made that ULT is indicated, while the patient is experiencing gout flare, we conditionally recommend starting ULT during the gout flare over starting ULT after the gout flare has resolved. This is contrary to what we used to teach to our doctors, but the recommendation here was not based on the risk of flare definitely increases when we start ULT during the flare. But the other point or counterpoint is that the patient, when doing this grade methodology, the group of patients said that they were highly motivated during the first flare, and it is better to start treatment to be motivated rather than asking them to come back for a second visit after the acute gouty attack has subsided, when the acute gouty attack has subsided, and losing the chance, because some of them misses this visit, and losing the chance of starting the medication. So they felt that the risk outweighs the benefit. The third recommendation is that for all patients taking urate-lowering therapy, for all patients taking ULT, we strongly recommend the treat-to-target strategy of ULT dose management that includes dose titration and subsequent dosing guided by serial serum uric acid levels or values to achieve an SU target over a fixed standard dose ULT strategy. For all patients taking ULT, we strongly recommend continuing the treatment and maintaining an SU below 6 milligram per deciliter over no target. For all patients taking ULT, we conditionally recommend delivery of an augmented protocol management by non-physician providers to optimize the treat-to-target strategy that includes patient education, shared decision-making, and treat-to-target protocol. Number 4, we conditionally recommend continuing ULT indefinitely over stopping ULT. Recommendations for patients taking specific urate lowering therapy, ULT medications. Number 1, for the allopurinol, we conditionally recommend testing HLA-B 5801 prior to starting allopurinol for patients of Southeast Asian descent, like the Han Chinese, the Korean, the Thai, and African American patients who have a higher prevalence of this gene. Number 2, we conditionally recommend against doing this test in all other ethnic groups. Number 3, for patients with a prior allergic response to allopurinol who cannot be treated with other oral urate lowering treatment, we conditionally recommend using allopurinol desensitization. But the physician should be experienced in doing this desensitization technique or approach. The febuxostat for patients with gout taking febuxostat with a history of CVD or a new CV event, we conditionally recommend switching to an alternative ULT. And this point was discussed earlier, and the recent studies do not support this point, but that's what the ACR said in its recommendation. Uricosuric for patients considering for taking uricosuric treatment prior to starting any uricosuric treatment, we conditionally recommend against checking urinary uric acid over checking urinary uric acid, because we said it's fallacious and it's more time consuming. For patients taking uricosuric treatment, we conditionally recommend against alkalinizing the urine. When to consider switching to a new urate lowering therapy strategy. Number 1, for patients with gout taking their first xanthine oxidase inhibitor monotherapy at maximum tolerated or FDA indicated dose who are not at uric at the target level and or have continued frequent gout flares or non-resolving subcutaneous tophi, we conditionally recommend switching the first xanthine oxidase inhibitor to an alternative one or over adding a uricosuric agent. Number 2, for patients with gout where XOI, uricosurics, and other interventions have failed to achieve the target and to have frequent flares or non-resolving tophi, we strongly recommend switching to pegloticase over continuing current urate lowering treatment. Number 3, for patients with gout for whom XOI, uricosurics, and other interventions have failed to achieve serum urate target and who have infrequent flares less than 2 per year and no tophi, we strongly recommend against switching to pegloticase over continuing current ULT. Gout flare management. Number 1, for patients experiencing a gout flare, we strongly recommend using oral colchicine, NSAID, or glucocorticoids in any way as appropriate first-line therapy for gout flares over interleukin-1 inhibitors or ACTH. The choice of colchicine or the other components, NSAID or glucocorticoids, should be made based on patient factors and preferences. Number 2, when colchicine is the chosen agent, we strongly recommend low-dose colchicine over high-dose colchicine, given its similar efficacy and fewer adverse effects. Number 3, for patients experiencing a gout flare for whom other anti-inflammatory therapies are poorly tolerated or contraindicated, we conditionally recommend using interleukin-1 inhibition over no therapy, like anakinra or kineret. For number 4, for patients who may receive an NPO, we strongly recommend glucocorticoids, intramuscular, intravenous, or intraarticular over interleukin-1 inhibitors or ACTH. Number 5, for patients experiencing a gout flare, we conditionally recommend using topical ice as an adjuvant treatment over no adjuvant treatment. Management of lifestyle factors. I'm left with 2 more slides. For patients with gout, regardless of disease activity, we conditionally recommend limiting alcohol intake. Number 2, recommend limiting purine intake. Number 3, recommend limiting high fructose corn syrup. Conditionally recommend weight loss. Conditionally recommend against adding vitamin C supplementation, which was advocated during the last decade of the last century as a cheap and easy means to lower uric acid without having too much harm, doing much harm for the patient or many side effects. But there is this conditional recommendation against it. The management of concurrent medications for patients with gout, regardless of disease activity, they conditionally recommend switching hydrochlorothiazide to an alternate antihypertensive when feasible. We conditionally recommend choosing losartan as an antihypertensive treatment when feasible, because it helps in lowering uric acid. We conditionally recommend against stopping low-dose aspirin in those who are taking this medication for appropriate indications like cardiovascular risk and so forth. Number 4, we conditionally recommend against adding or switching to fenofibrate. I hope this presentation was not boring to our audience, and thank you very much for listening and following my presentation. I'm done, and thank you again.
Thanks a lot. Dr. Gafar?
Yes.
Again, Fikri, Assistant Professor of Rheumatology at Azhar University. Thanks a lot for this amazing, informative, updated lecture. I enjoyed every minute of lecture. I'm so sure that my colleagues have a full benefit of clinical practice and for diagnosis and management and the recent guidelines of gout. Thank you, Dr. Gafar, and I ask my colleague if any of them have a question for Dr. Gafar. Please type it in question and answer button. Thank you again, my dear professor.
Thank you.
Thank you
for having me.
Thank you. Now I will introduce my mentor, instructor and teacher, Professor Dr. Adham Al-Futuh, ULR certified trainer. Dr. Adham spent a lot of time for training and teaching musculoskeletal ultrasound after introduction of it to the Egypt since 2010 up till now. Dr. Adams is a scientific director of Egyptian School for Musculoskeletal Ultrasonography, president of Egyptian Society of Musculoskeletal and Neuromuscular Sonography. He have a clinical attachment in a practice program Madrid, Spain, and at University of Bath at Cppd modules and distant learning. Many memberships at ACR, British Society of Rheumatology, EGYSIR, as a founder and as a scientific director of the Musculoskeletal School, and he is an international conference volunteer. Dr. Adham has scientific activities and publications which are dedicated to musculoskeletal and neuromuscular ultrasound in rheumatology, and he was a lecturer and instructor at many of ULR scientifically endorsed musculoskeletal ultrasound courses in Europe, Africa, and Asia, and also international courses in Europe. He conducted and organized many international and many local courses from basic to advanced level in Egypt for musculoskeletal and neuromuscular ultrasonography. He awarded many times from Egyptian ambassador in Kuwait and from annual ceremony for doctors, honoring doctor, and honored from many universities and hospitals for his effort in teaching and training musculoskeletal and neuromuscular ultrasonography. My dear Professor Dr. Adham contributed 3 book chapters to textbook published by international publisher Springer Nature. soft tissue rheumatism in musculoskeletal ultrasonography in rheumatic diseases, and osteoarthritis in comorbidity in rheumatic disease, and lastly, knee and leg chapter in pediatric musculoskeletal ultrasonography. So be ready for interesting and interactive session with Dr. Adham Abou Futuh. Let's start, Dr. Adham, please.
Thank you very much, Dr. Iman, for the nice introduction. It's really a great pleasure that I will be speaking following Professor Ghaffar, a world leader, doctor and researcher, and an excellent clinician. It's really a great pleasure. And also he made my lecture, I think, much easier now to concentrate on the ultrasound. So please confirm that you can see my presentation at full screen. Amen.
أيوة.
The screen, okay?
Okay.
Okay, thank you very much. This is a slide zoom summary of my presentation. So you'll be following up each and every section. So you have the anticipation when you will finish if you get bored in the middle. If we speak about musculoskeletal ultrasound in gout, then we are speaking about crystal deposition, Tenocynovitis, Synovitis, Tenocynovitis, Erosions, Doppler, and using it to determine active inflammation, tophus, chronic damage, treatment responses, and guiding injection, aspiration, and or biopsy by ultrasound. I would consider, as so many citations, this paper by Professor Ghaffar Ragab and his colleagues, a reference for gout, as already mentioned. Not only putting the ultrasound images, I had the pleasure to supply it, showing the tophus, the double contour, the tenosynovitis with crystal aggregates, but it has a lot of comprehensive updated review for gout that I personally benefited in my clinical practice. We can look at the gout or the signs in the ultrasound by different ways. So this paper spoke about specific and non-specific signs of gout. For example, it said that non-specific signs of gout is joint effusion. And of course, following each highlighted term is the definition. But I will put you the exact comprehensive paper reference for definitions if you want. So the joint effusion is anechoic or hypoechoic intra-articular material that is compressible and displaceable and cannot give Doppler signal, while synovial hypertrophy is the same but not displaceable and can give Doppler signal. The snowstorm appearance of synovial fluid, which is a hyperechoic spot suggesting crystal disease, unfortunately is considered by this paper a non-specific view. And bone erosions, juxta-articular cortical irregularity, as Professor Ragab mentioned. And of course, bone erosions only, without describing them, is non-specific. Personally, I learned the differential diagnosis from him a long time ago, when he used to tell me that the differential diagnosis of bone erosions are rheumatoid arthritis, psoriatic arthritis, gouty arthritis, septic arthritis, and erosive osteoarthritis. By just mentioning erosion, it would be non-specific. If we speak in details like he mentioned in the different radiological modalities, it can get more specific. While more specific signs of gout can be the double contour sign, which is the hyperechoic irregular band over the superficial margin of the anechoic cartilage. If you remember, the hyaline cartilage of the bone, of the joint, is anechoic because it's about 78% water, and the water is anechoic in ultrasound. And it should have a thick, deeper or lower line because this is the bone line, while a very sharp, indistinct upper border because it's the interface between the upper border of the cartilage and the soft tissue. In this double contour, we get precipitation, and then we get this tram track appearance or double contour sign, which you can see a lot of authors speaking about. And of course, tophus, as mentioned by Professor Ragab, the echoic to hyperechoic, non-homogeneous mass that can be surrounded by a small rim of hypoechogenicity and can have or not back shadow. Hyperechoic soft tissue areas, bright dotted foci in synovial fluid, those would be non-specific to gout, but if found in the synovium with tophus, they would be, or in the tophus, they would be highly suggestive. So this is the comprehensive paper published by the EULAR-UMR Act Committee, which is inclined to define the ultrasound radiographic pathologies and elementary lesions. Why did they say 15 years on? Because they had the first paper published in 2005, and this was an update 2019, almost 15 years from the original one, and they modified certain definitions. And if you want, you can go back to the paper in details, because it also mentioned a lot of terms that we will explain today, like the double contour, the tophus, the crystal aggregates. I already mentioned them, but I mean the official or the formal terms can be found in this paper. So in a diagrammatic way, to be simplified, just simplification, the general inflammation would be synovitis. And as you know, synovitis is a common feature between a lot of rheumatological disease. So our journey today will be speaking about how to differentiate the synovitis of gout from the synovitis of other diseases. Tenocynovitis, and it entitles the same characters. It's common across many rheumatological disorders, subcutaneous edema. And although they say it's a general inflammation, and although this is true, I just put 2 exclamation marks, and I will be saying some tips and tricks while we are going along the journey of gout with ultrasound today. For example, I noticed personally that the subcutaneous edema is much more common with the gout than when any other synovial inflammation or synovitis. For sure, much more than rheumatoid arthritis, for example. This is a character, and it can resemble actually something like cellulitis image when you have gout. What is specific to gout would be the crystal deposition. The most common form of crystal deposition would be the double contour sign that Professor Ragab pointed to, and the tophus. And the tophus, just to start with, can be intra-articular, in the tendon sheath, in the soft tissues, anywhere. The tophus can happen almost anywhere. So we are done with the first section, and now we are going to speak about acute arthritis. I am sure if we are going to speak about acute arthritis, a lot of you are aware of the findings, and probably you're waiting for the tips and tricks how to differentiate the arthritis associated with gout than those associated with the other diseases. So I got you this updated paper published in 2020, putting this differential diagnosis of inflammatory arthritis by ultrasound in a systematic literature review. And I am just giving you the background that is written in this paper for simplicity. The hypothesis is distinct treatment strategies for different rheumatological problems exist. So nowadays, we cannot take things by shadow or by lights. We have to really specify which type of rheumatological problem we're dealing with. Each and every one has a specific treatment. We have to have a prompt, early, and sure diagnosis. There is uncertainty, which is high, especially early in a lot of diseases, including the gout and other ones. The ultrasound can provide dependable tool early in the disease, which is, of course, a great plus. However, most ultrasound studies can easily provide elemental lesion descriptions. And for those wondering about elemental lesions, meaning when I'm speaking about erosion, osteophyte, synovial hypertrophy, synovial effusion, those are elemental lesions. But more complex combination is usually needed to reach the diagnostic specificity and valuable differentiation for diagnosis and follow-up. This is very, very important because if you are dealing with, for example, a suspected case of rheumatoid arthritis, if you mention that the patient has erosions, this is not enough to diagnose rheumatoid arthritis by ultrasound. And the same with gout and some rheumatological diseases. We need combination of factors. And not only this, but we also need to combine this with the clinical history and examination that we learn to do for the patient. Until recently, the real situation depends slightly on the ultrasound. And for example, most studies concentrate in RA on synovitis. So, and we have just said that the synovitis is actually common across so many rheumatological diseases. So mentioning synovitis is not really helping. And until recently also, polymyalgia rheumatica was the only disease with explicit specific importance in the criteria to mention explicitly ultrasound. Things are getting more and more, and as Dr. Ghaffar explained to us all the new criteria, they are getting added, the ultrasound, I mean, is getting added to the criteria. So the paper I mentioned in the systematic literature review, they studied the different rheumatological diseases and mentioned that the ones concerned with psoriatic arthritis and osteoarthritis mostly studied the prevalence of different lesions in already diagnosed patients. Okay, so they got already diagnosed psoriatic arthritis, already diagnosed osteoarthritis, and they are studying the prevalence. While in RA, studies are vast and extensive, and they evaluated the added value of ultrasound over any classification criteria or some of them, and added value on top of clinical findings, because ultrasound can increase the sensitivity, and evaluated the prognostic value over the future development of RA. And in the RA recommendation, I have mentioned so many times the studies that showed that the ultrasound and Doppler can really predict future activity. The polymyalgia rheumatica, we have good luck that some studies had consecutive patients with shoulder pain, and some studies evaluated the 2012 diagnostic criteria. In gout and CPPD, we stand in the middle. So we have people with monoarthritis. Thank God they are not diagnosed yet, but we suspecting with monoarthritis, of course, the crystal arthritis. And those are the number of studies done for each disease to evaluate which one. This is like a table to summarize the things I mentioned. And for the gout, we have only a few studies to provide evidence in diagnostic performance of ultrasound using the systemic literature. Those are the elemental lesions studied, and you can find that the synovitis is much more studied than erosions, for example, and effusion or tenocynovitis. The one with darker line then is comparing some elementary lesions, one over the other, or one over the criteria. And you can see that erosions, effusion, tenosynovitis, enthesitis, bursitis, tendinopathy, and so forth, using soft tissue inflammation even is used. So if we take synovial hypertrophy or synovitis and to compare, for example, the most common presentation, which is RA against the gout, you can see in the RA, the synovial hyperplasia can be really found in most of the patients. Few patients, especially early in the disease, has no synovial hyperplasia. The total opposite happens in gout. And I will explain why you have some synovial abnormalities in gout, but they don't qualify to synovial hyperplasia. For example, this is the first MTP, and you can see here that you have abnormal material, and you can think that this is synovial hypertrophy or synovial hyperplasia. On the contrary, this is what we call snowstorm appearance. So you have starting deposition of crystals over the superficial layer of the anechoic cartilage, and you have shiny spots inside. And if you apply pressure, you can find that most of it is floating and displaceable. So this is the snowstorm appearance that we see. While in rheumatoid arthritis, in addition to the anechoic effusion, you can see echogenic tissue, and usually is related to the lining of the capsule. So you can find it at the edge or proliferating inside the joint, the cavity. So you can see abnormal tissue, and this is what we call synovial hyperplasia, but this does not qualify. This we call it snowstorm. The other thing is you can see in the rheumatoid arthritis, the synovitis is marked synovitis. We have erosion. We have pannus formation invading into the bone, making this hot erosion, destroying or destructing the cartilage. while in the gout, you can see some synovial tissue Doppler. Usually they are shy, and the others are related mostly to the intra-articular tophi. So the tophus can have Doppler activity in or around sometimes, and most of the joint would be free from the synovitis. Never mind that in some cases we can find synovial proliferation or hyperplasia, but also not necessarily going through the same image as the rheumatoid arthritis. So we go to another point with differential diagnosis, erosions. So the same systematic literature review, this clear paper that says that bone erosions boundary can be seen clear in the gout group than in the rheumatoid arthritis group, while it is blurred in the rheumatoid arthritis group than the gouty group. That is to say that probably if you compare erosions among RA and gout, you can have bigger erosions, well-defined boundary in the gout group and not in the rheumatoid group. Let's see some examples. So here we have the gouty group with two erosions, one small, one big, or one smaller and one big, because this is not very small. But you can see that the erosions are really big, like Professor Ragab said. It's even in the plain X-ray, they look punched out and well-demarcated boundaries. So here in the ultrasound, they look the same, and usually they are bigger earlier in the disease than in rheumatoid arthritis, where you have an erosion here and an erosion here. And I would say this is not an early disease. It's an extensive disease of RA and not very early. And you can still see unclear boundary at least in the cortical bone line, unlike the one punched out in the gout. So, one trick is to look at the MTP from the medial side. This is an MTP joint from the medial side. It's more peculiar in showing very large erosion where well-demarcated borders and very sharp boundaries. And they will remind you of the ones detected in X-ray. Bear in mind that the studies on rheumatoid erosions, for example, mentioned that the ultrasound is 7 times sensitive and much earlier than the plain or the conventional X-ray in detecting erosions. And also the studies show even more sensitivity with ultrasound than MRI in detecting erosions in gout. They are just less sensitive than the CT, like Professor Ragab explained. One old paper mentioned that the combination of joint effusion, tophus, erosion, and hyperechoic irregular band, which is a double contour, is said to be diagnostic in about 97% of cases. All these findings can be seen with ultrasound. I bet there are more recent studies with less signs and more sensitivity. So let's talk in academic ways and explain how ultrasound is used in guidelines. It is very important to concentrate in this area. Professor Ragab explained that there are two, there was a 2015 gout classification criteria put by the American College of Rheumatology, combined with the European League Against Rheumatism, the EULAR. So I will not go through the details, but I will highlight the area that we need to concentrate on. So it is this note number 7, imaging evidence of urate deposition, and the categories are absent or not done or present, either modality. Either modality is ultrasound or DECT. Professor Ragab explained exactly how DECT is more sensitive and preferred way of imaging, despite having some disadvantage of radiation. While ultrasound is easy to perform, bedside or clinical side, you can see the double contour sign on ultrasound or urate deposition on the DECT. So these criteria of 2015 by EULAR, American College, ACR, and EULAR. Now, also, Professor Ragab explained about 2018 EULAR evidence-based recommendation for the diagnosis, and also regarding this point, when a clinical diagnosis of gout is uncertain, and crystal identification is not toxical, patient should be investigated by imaging to search for monosodium urate crystal deposition by features or of any alternative layers. This is a very common thing because if you read until now, the gold standard for diagnosis of gout is aspiration of the synovial fluid and detection of the crystals. We all face everyday life where you have a very suspecting or suspectful case of gout that you cannot really aspirate, whether due to technical shortcomings, due to time issues, or due to patient refusal of the procedure. I would add a tip here that you also, if you aspirate and you don't do the test quickly by the microscopes, you might get non-specific readings, because this is what I get in a lot of gouty patients that are proven by so many ways, but not with a detection by polarized light microscope. At least in Egypt, I see this shortcoming. The report would come back non-specific crystals or no gout, although that you are sure that this patient is in acute gouty attack. So it seems that like we have to speak about the crystal deposition. It's very, very important. And the monosodium urate crystals that Professor Ragab explained can be seen in synovial fluid, synovium, tendon, bursa, cartilage, bone, everywhere in the body. So the first way to detect the crystal deposition is the double contour sign. And the double contour sign is precipitation of monosodium urate on the superficial layer of the hyaline cartilage. Hyaline cartilage is the articular cartilage. So if this is an MTP joint, this is the metatarsal head. It should be covered by a black area of hyaline cartilage, and the upper layer or the superficial layer of the cartilage is undetectable, but the lower area, the lower surface is usually the bone. That's why you have thick layer here and thin layer inside. In gout, you have precipitation of the monosodium urate crystals over the superficial layer of the hyaline cartilage, performing the double contour, very specific sign in gout. But as a tip, you have to differentiate this from the cartilage sign interface. This cartilage interface sign is a normal finding where you have the ultrasound wave perpendicular to the cartilage. And here we have the angle of insonation would produce this sign. Actually, this can be a normal sign, and it is actually recommended to get it when you are measuring the articular cartilage. For example, when we are following up diseases that can corrode the cartilage, like rheumatoid arthritis, you have to get this superficial cartilage sign to measure, so you are sure you are measuring the best cartilage thickness. Also, I see some posts everywhere about double contour sign, and honestly, it does not qualify to be a double contour sign. It's just a cartilage interface sign. Especially, you would have this as normal, or if you have joint effusion or effusion above this superficial layer, because as you know, with a fluid, it would enhance the transmission through it for the ultrasound waves. So you can get enhanced image of the superficial layer forming this cartilage interface sign. But this sign does not move and is always present here in the most perpendicular area, and you cannot detect in the rounded contour of the metacarpal or metatarsal. In this joint, the MCP joint, you can see that we have also double contour. The thing is, I want to brainstorm with you tonight, saying that you can actually see the gout in very unusual presentation. For example, when they say you can see it in the knee, you can see it in the ankle, you can see it in the first MTP. Actually, I see a lot of gouty patients in every joint almost, and presenting as polyarticular disease, because this differential diagnosis of rheumatoid is polyarticular and the gout is monoarticular. Maybe this happens early in the disease, but a lot of patients later on, they present just like rheumatoid, polyarticular. They can be bilateral, usually not so symmetrical, and usually you have the chronic tophus, but sometimes they present with camouflage, and like Professor Ragab also explained, they can be tumescent gout or the presentation of both diseases together. So by seeing ultrasound, you can really detect the findings. And although MCP joint is an RA joint in this tumescent gout, actually it was presented by double contour sign. And not only this, but also intra-articular tophus saying that if we have abnormalities in this MCP joint in patient with rheumatoid arthritis and gout together, I would refer most of the findings to gout. A very old trick that you can use the original brightness that you use, the gain that you use with ultrasound here to see the double contour of the MCP joint together with the overlying cartilage, overlying tendon. So you can see a lot of tissues here, the bone, the cartilage, the double contour tendon, the joint, the double contour sign, the joint and the tendon, very clear. Here I reduced the gain very much. It was 64, the ultimate or the best gain. Here I used almost half the gain to nullify the soft tissue picture or image, except that the double contour was still seen. You know that the hyperechoic line of the bone can be seen with the minimal gain, and also this crystal deposition of double contour. So this is just another trick to differentiate the double contour from any soft tissue interface artifacts. This is another gouty patient who has tophus, synovitis, double contour sign of the MTP, widening of the joint space. Here the gain was high. Here again, I lowered the gain so much so that most of the soft tissue findings are nullified, except the bone line and the double contour line another way. And you can see that the double contour is present also in the rounded area of the metatarsal head, not specific to the interface sign here, where the ultrasound is perpendicular. So please don't take it an easy way to overestimate double contour and easily camouflage the interface sign as double contour. This is double contour. I remind you of this view of the knee when we have full flexion, looking at the femoral hyaline articular cartilage, and it looks like this in the healthy individual. So this is the bone line, the deeper line. This is the superficial line where the cartilage interface with the soft tissue capsule, and this is extra articular. So you can see that the outer line is just distinct, but it is not, it is very sharp, it's very distinct, but it's not as thick as the bone line. While here, you can see that we have the position of monourate crystals in the inner line forming the double contour sign. And this is just a differential diagnosis of another type of crystal arthropathy, where you have the calcium pyrophosphate dihydrate crystals deposited in the middle of the cartilage. So this is not double contour. This is deposition in the middle, inside here, but the gout has a double contour. So this is Cppd disease. This is gouty disease. Tophus is a very important structure to look at with ultrasound. It has a peculiar deposition, structure and peculiar shape also on ultrasound. So it is complex, organized, chronic inflammatory response to the monosodium urate crystals. And the exact structure of the tophus would involve the innate and adaptive immunity cells. It is very detailed and complicated, but I would say for simplicity, there is a fibrovascular matrix containing a core of monosodium urate crystals, lipids, then cellular debris, and they are surrounded by a cellular corona of granulation tissue. And this hint of structure, this is a very simplified structure, is the structure of those tophi that we see in this patient with profound gout, chronic tophaceous 1, that we will see with ultrasound. So if this is the MTP1, again, this is the MTP1 joint, very common for the ultrasound, for the acute gouty attack, like Professor Ragab mentioned. This is a tophus, or exactly microtophus, where you have a small size heterogeneous material surrounded by anechoic line related to a corner or intra-synovial. If we see the same joint with grayscale and then the same joint with Doppler ultrasound, you can increase the confirmation, because as we said, the tophus can be surrounded by hypoechoic rim like this one, and like this one. And also it can be surrounded by Doppler. Here we have a shy synovial hyperplasia with Doppler as well. A PIP tophus, also maybe for a lot of you, uncommon site for the gout. Likely enough, we can see the bone, the joint here, and you can see two big tophi, and you can actually get amazed how this is hard tophus. This is mixed tophus, hard soft, and you can see the material here moving in the center of the and you can see some hard layers, and this is intra-articular, so you can be amazed how much this joint recess can actually take. Bear in mind that the tophi are not specific to joints. We can see them also in tendons. So this is a tendon where we have tendon sheath with aggregation, and the aggregation is marked, and this is like tophus rather than just crystals. This is tophus in the tendon sheath. So you can see this a lot. You can see it even inside the tendon. So this will take us also to the next section talking about tenosynovitis, but like I explained, tenosynovitis is not specific to gout. So probably you're now wondering about what can be specific in the tenosynovitis to gout, so that you need to give a feedback to the referring physician. Why are you saying that this tenosynovitis is gouty? So when you perform dynamic examination of the tendon, you can see huge swelling here forming a tophus in and around the tendon, inside the tendon sheath, irregular material, inhomogeneous with hyperechoic dots, can be or cannot have back shadow, and cannot have Doppler signal. Take your time, trace, go dynamic. We stand with the ultrasound a very good advantage over the cross-sectional modalities of imaging, that you can move either your probe, your hand, or even the joints of the patients to study dynamically, because a lot of times when you do dynamic exam, you can really get some images. So this is a tendon that shows hypoechogenicity around it, so it is like tenosynovitis. I rotated the probe 90 degrees to look at the longitudinal section. This is also the tendon sheath distended with effusion. But when you trace further and further, you can detect how much the tendon is inflamed, if we have crystal deposition or no, if you have crystals inside the tendon sheath, if you have tophi to appear like this one here. This is an intra-sheath tophus that appears in the tendon sheath around the tendon. So please take your time, trace, and go dynamic. This is a tendon. This is not the tendon. This is crystal deposition. This is tophus. So you have to have a peculiar image and trace. Moving the ultrasound can give you a lot of details. Tenosynovitis as present in cross-section. This is a tendon surrounded by hypoechoic rim. So this is effusion. Tenosynovitis tendon longitudinal image over the flexor side of the hand. And this is tenosynovitis. Of course, this is an example of non-specific tenosynovitis. You cannot see this one and mention anything about gout, but you can combine these elemental lesions with other findings to say gout. By applying this is a transverse view of the extensor digitorum longus in the ankle. Of course, this is a huge swelling around the tendon fibrils, and you can have a Doppler signal. And usually when you have very extensive swelling like this, search for crystal precipitates or deposition around the tendons, and usually it is gouty related. Even the snowstorm appearance and the tophus can be seen in the tendon sheath. So this is the tendon, and you can see here gouty tophi, crystal deposition, snowstorm. These are the tendon fibrils, and there's dehiscence in the tendon. I will rotate the probe to look longitudinally, and you can see a lot of tophi. These are all tophi with crystal aggregates and micro and macro tophi, together with a snowstorm appearance. So this appearance of tenosynovitis resembles the one I showed in the beginning of synovitis. It is unlike the synovial hypertrophy of the RA and psoriatic arthritis. This is more of snowstorm appearance. This is the tendon where you have also snowstorm and some crystal aggregates and tophi with Doppler in the longitudinal fashion in the cross-sectional area. This is how it looks. This was an extensive view of the patient with active disease. Not so much remaining. Remember, you have to concentrate on what I'm saying because there's an interactive session at the end. There are some questions and answers, and I will hold a prize for the best answers. So also bursitis is a non-specific feature of gout that you can make it specific using the ultrasound. So let's see. This is a normal Baker cyst. You can measure it. You can see synovial hypertrophy and some also fibrous septation. So it can be related to any other inflammatory disease. While this one is full of snowstorm appearance. So there's a background fluid that is inhomogeneous and usually hypoechoic alternating with echogenic areas with hyperechoic dots that might or might not be having back shadow. So this is how a gouty bursitis might appear. This is typical. This is not typical. So you can also use the appearance of something that is common between so many diseases to differentiate between gout and non-gout disease. Mind you that when you aspirate the bursa, just leave a little bit of fluid, maybe 1 or 2 cc's of fluid, so that you can see the needle. And here I am injecting injectate. But this is not why I am showing this. I am also showing this to tell you that taking history is very, very important when you see this image, because this image looks like snowstorm appearance of gout. Please ask the patient if he or she had in local injection in the weeks before he comes to you, because this might be only the injectate, okay? So this is a very common differential diagnosis beside the diseases. Also, the injectate in the bursa can look like snowstorm appearance, okay? So before the final points, we can use also the ultrasound to check for joint chronic changes. And this is very peculiar. I will show you very, very prominent images. This is one patient who came for this joint with chronic changes. This is the MTP on the second side, where you have the metatarsal head, the overlying cartilage, normal synovium, and the base of the proximal phalanx. The joint is almost normal and maybe beginning of early osteoarthritis. Same patient on the other side where he used to have gouty attacks. We have here erosions, osteophytes, big erosions here, large osteophyte. Bear in mind that the space between the bones or the joint space is almost nullified and the the bone is overlying each other and the joint is destructed, widened maybe like as a distance, but very narrow space between the bones. So this is chronic sequelae of repeated acute gouty attacks in MTP joint. This is the same patient, the other side, normal MTP. So if you see this, don't mention that this is just osteoarthritis. Mention it is unilateral osteoarthritis. It is profound osteoarthritis to age. This might be the sequelae of previously attacked joint. If you use dynamic examination for MTP joint, you can see very peculiar. See, this is one bone. This is the second bone. This is MTP joint, very destroyed. Anatomy is not obvious, but I would tell you, erosion, large osteophytes, some effusion. The bone is overhanging each other. There is nullified joint space and destroyed bone contour. This is, of course, the sequelae of chronic gouty arthritis. Now, just a small or just few words about the monosodium urates and Cppd crystals. The Cppd is the calcium pyrophosphate dihydrate crystals that can cause what we used to say pseudogout or chondrocalcinosis or Cppd disease. Bear in mind that the types of crystals are not only limited to the monosodium urates and the calcium pyrophosphate. There is also basic calcium phosphate, and these are also subtypes of basic calcium phosphate. But just for simplicity and common, I would concentrate on the monosodium urate and Cppd disease. So the distribution of the gouty crystals is mostly para-articular structures like tendon, ligaments, and bursae. Intra-articular are less prominent and maybe monoarticular or polyarticular. Like I told you, I see a lot of polyarticular gout. The first metatarsophalangeal joint in acute phase, but in any joint after that can happen, especially in the chronic phase. And exactly like I said, in the chronic cases, you can see polyarticular bilateral affection, even in joints peculiar to other diseases. In Cppd disease, mostly articular tissue, either hyaline cartilage or fibrocartilage, synovium, capsule, or ligament, and usually polyarticular in knees, sepsis pubis, and wrist. This is a very common differentiation between the monosodium urate and Cppd, whether in the distribution or in the ultrasound. Like we said before, the gout appearance might be double contour, tophus, aggregates, erosions. In acute phase, you can find the non-specific synovitis and hyperemia in the tophi that we try to make them very specific to gout if we can. While in the Cppd disease, the hypoechoic deposits in the middle layer of the cartilage, like I showed you, this in the fibrocartilage is different from the hyaline cartilage. The hyaline cartilage is black, anechoic, jet black, but you can find dots in the center of the thickness of the cartilage. And this is a starting Cppd disease. In the acute phase, you can also see synovitis and hyperemia. And by the way, as a clinical tip as well, because I see this in a lot of patients, acutely, when you have unexplained acute inflammation that is not really related to only osteoarthritis, only gout, and you can see that there is more profound inflammation and the patient is not rheumatoid or psoriatic or something like this, and the age is suspicious, of course, in older age, try to think about this missed disease, pseudo-gout. It could be Cppd disease in association with other things. In the chronic disease, however, you can see the non-responsive osteo. The non-responsive osteo is not all in the category of erosive osteo or inflammatory osteo. There is also this osteoarthritis associated with Cppd disease, and usually this Cppd entity gets lost, and that's why even with oral medication or injection, the disease does not give you a satisfying complete remission. Think about Cppd. The sites for the Cppd, actually, in one study was 100% sensitive when you see it in sepsis pubis, the knee, and the wrist, the triangular fibrocartilage. However, this is, you have to raise this question mark because this is not so early, and this is not so acute, and it is not specific when you see other sites. Because honestly, commonly, we see Cppd disease in other sites, and to see it in a plain radiograph deposition, it is not early, and it will not tell us about the acute inflammation. It will only tell us about the crystal deposition. So the Cppd crystals would deposit as fine linear or punctate pattern, so punctate dots, and then fine linear following fibrillar architecture in the affected joints. And tendons, where Cppd crystal deposit between fibers. In the cartilage, crystal tend to deposit in the middle layer of the cartilage, organized in a linear pattern parallel to the subchondral bone. So this is how it looks. This is the knee articular cartilage. We have started dotted precipitation in the middle of the thickness of the articular cartilage. And here we have a very prominent linear deposit in the middle of the jet black echogenicity of the cartilage. Of course, needless to say that the ultrasound might be so sensitive earlier before this line can show even in a plain X-ray, forming the classical picture of chondrocalcinosis. You remember the triangular fibrocartilage? This is the view. The view is like this when I put the probe on the medial aspect of the wrist, looking at the extensor carpi ulnaris ligament and the tendon and the ulna together with the carpal bones. This is the triangular fibrocartilage complex of the wrist, and it looks here normal. Then here you can compare to this one with crystal deposition. This is very peculiar in CPPD disease in older age. This is the extensocarpi ulnaris, and this is CPPD crystal deposition in the triangular fibrocartilage. If you take it in a dynamic stage, you can see the crystal deposition clearly. So it is not just a mere accidental finding by the perpendicular ultrasound waves. It is a true precipitation in the deeper part of the triangular fibrocartilage, very pathognomonic of CPPD disease. If you need to do further reading, there is this book. I had the honor to participate with another chapter called Soft Tissue Rheumatism. This chapter was written by my friends and colleagues, Rodina from Bulgaria and Daniela Fuder from Romania. And they wrote a very nice chapter, reference of ultrasound finding of crystal-induced arthropathies. And now we will head to the interactive session where I need to see some answers to those questions. This is probably a nice, interactive, quick, and pleasant combination of images. So can you tell me this image, what does it show here? This is the hyaline cartilage of the knee, the femoral hyaline cartilage. What diagnosis what does it present? I will check the answers. So can anyone tell me what do you see here? Okay, a lot of the experienced have answered CPPD, 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 hyperechoic deposits. Very clever, Dr. Murphy. Okay, yes, a lot of you, crystal deposition with double contour, crystal bony sclerosis, CPPD. Go on. Pseudo gout, CPPD. Okay. Double contour. So there is controversy about it. Okay, here is the answer. I would say more answer. Deposition in the middle of the cartilage, CPPD, CPPD. So maybe the most have got the correct answer. This is CPPD disease, and I will tell you why. So I will show you that this is another image of the same patient showing clear outer line here without any crystal deposition. And there was a faint intermediate line in the middle of the cartilage. And if you take it dynamically, then you can see that the deposition is in the middle. Here is the outer line free. This is the middle of the cartilage. So it is truly starting from punctate to be a linear deposition. And this is a CPPD disease. This is the first MTP joint. So what do you see? I'm sorry, I put the answer, but I would wait for you to tell me. Which disease? Which disease and why? Yes, snowstorm. Okay. This is an MTP, snowstorm gout. Yes, gout, snowstorm. I think most of you are right. And I know not because you have seen my answer, but I think because you have seen that before and you're clever to detect it. This is snowstorm synovitis. It's mainly heterogeneous or inhomogeneous material filling the interarticular space, distending the capsule. Hyperechoic dots, usually inhomogeneous, and you can see later on starting deposition of double contour. So true, most of you are true. This is gout, and this is the snowstorm appearance. Okay, do you remember the this medial longitudinal view of the knee, where we look at the femur, the tibia, the anterior horn of the medial meniscus, and the medial collateral ligament? And you can see that the anterior horn of medial meniscus is homogeneous. Okay, and what is the difference between this and that? So what do you see here? Which disease? What finding? Which disease? I want you also to concentrate on, okay, don't give me only the diagnosis, but give me what you see, because can you see the upper part of the anterior horn of the medial meniscus? This is the peaked part. This is the base. The base is within this bone line, but here the base is outside the bone line. So you have to tell me what happened to this anterior horn, and what do you see? Let me see the answers. CPPD, tophi, calcium deposits, tophus, CPPD, punctate deposits, degeneration and extrusion. Yes, exactly. You are correct. I will wait for a few more answers. Tophi. Hyperechoic deposits. Yes, okay. Now, what I would say that those bone lines here became very close in this area. So we have reduced joint space. This is mostly presenting osteoarthritis. Second, the base of the anterior horn of the anterior horn of the medial meniscus was extruded outside. So this is extruded meniscus that you can see also in osteoarthritis. This is homogeneous anterior horn medial meniscus. This is an anterior horn of medial meniscus that degenerated because we are losing originally how it looked like, because the fibrocartilage would look echogenic. Here we started to lose this echogenicity, and also we have hyperechoic dots, and this is very specific to CPPD. And this is a very excellent example to those patients with osteoarthritis that do not get better with your treatment because they have pseudo-gout or chondrocalcinosis or Cppd disease concomitantly with osteoarthritis. When, of course, if you can see clefts, you can see degeneration, you can see probably later tears. This is the sequel of osteoarthritis together with Cppd disease. This is a bigger image of the finding. I do not qualify to see the cleft, but it is not untrue. You can see it, it's not uncommon. Extruded meniscus, narrow joint space, precipitation of crystals, old age, then we're talking with Cppd disease. This is a dynamic examination where you can see osteophytes, reduced joint space, extruded material. This medial collateral ligament is also affected by strain, and you can see the Cppd crystal deposition, very typical of Cppd disease. Now, this is a dynamic examination. Which elementary lesions you can see? This is MCP joint, metacarpal head, base of the proximal phalanx, and this is a joint. Which lesions, elemental lesions you can see here? One lesion. Which lesion do you see? 2 lesions, 3 lesions, 5 lesions? What do you see? Elemental lesions. So I mean osteophyte, erosion, synovial hypertrophy. These are the elemental lesions. What can you see elementally here? Tophaceous, double contour, tophi and synovitis, double contour and macrotophi, tophus, synovitis. Very good answers. One missing still. Synovial effusion, hypertrophy, double contour and tophus. Okay, most of you got the good answer. I will just repeat the video to show you that maybe we have an erosion here and maybe not, because this area can be very difficult in diagnosing erosion because usually there is a notch before the metacarpal head. So you have to be very careful saying we have erosion. But we have interarticular tophus, heterogeneous with hypoechoic rim. We have double contour sign. We have distended synovium. So you all got the correct signs exactly. And this is, now which lesion do you see here? Which lesion? Again, I need elementary lesions. So which elementary lesions can you see here? which elementary lesions you can see here. Now a lot of you got the erosion. Okay, the double contour, you're right. So which disease? Erosion, erosion, gout, erosion, double contour, erosion, double contour, erosion, double contour. Yes, you're right. And this is a very nice differentiation between this video that shows clear-cut boundary of a punched out erosion of gout, while the aerial video showed just a metacarpal notch. Okay, this is a very common mistake even in people who say they are experts with ultrasound. Don't diagnose easily an erosion in this notch. A lot of answers: double contour, double contour, double contour. Yes, double contour, but don't forget the erosion. Last question: is this acute or chronic? This is the last question for you, and I will end up my presentation. Is this acute or chronic? What can you see in this image? Acute. Acute. Okay. A hint: if you see a Doppler signal in synovitis in the joint, this is acute inflammation. Anyone else want to say anything else? Who is Shuru Abu Saleh? Because I know all the other who answered the correct question, they are now teachers. Shaker, bravo. Yes, exactly. I want to tell you that this, despite the fact that you can see distended joint space, synovitis and synovial proliferation, Doppler signal activity, which can 100% say this is active inflammation. You can see also erosion, osteophyte, reduced joint space, widen the joint recess. So this is an image of osteoarthritis, chronic changes, together with acute changes of synovitis. Maybe this is acute gout on top of old gouty attacks or osteoarthritis, whether primary or as a secondary to previous gouty attacks. So this is acute on top of chronic inflammation. And I'm sorry that it was a little tricky. I would thank you very much for holding tonight with us and listening to our presentation. And I will be very delighted together with Professor Ragab to answer your questions briefly. So, Dr. Iman.
Thanks a lot, Dr. Adham, for your excellent presentation. I enjoy it, especially tips and tricks, interactive session, and your marvelous sense of humor. Thank you. And now we will start to answer the questions. The first question to Professor Dr. Gafar Ragab. Dr. Gafar موجود؟ Gafar,
I'm with you.
the first question: after what period should be I switch the treatment and considered failure?
Number one, we have to bear in mind that it's a targeted level. Treat to target. The target is to lower uric acid level to below 6 milligram. So it's not dose dependent. Usually targeting treatment to this target will get a lower serum uric acid level, more adherence to the treatment, shrinkage of the tophi or improvement of the size, and more and above that will have less frequent flare. This period, if we fail to achieve this result, it's a matter of weeks to months. I do not mean 2 months, weeks to months. I would say from 3 to 6 months, which is the usual duration between visits for rheumatologists, unless there is some flare or some deterioration of the condition. So I would say weeks to months, but always adhere or stick to your target of below 6 milligram per deciliter.
Okay, thank you. Another question for Dr. Gafar. if there is any indication for treatment of high hyperuricemia in asymptomatic patient with no radiological finding.
We do not treat asymptomatic hyperuricemia, but actually this point should need some consideration from experts in gout because the availability of more recent modalities like the ultrasound and the DECT, for example, will allow us to detect that crystals are starting to deposit before showing gout. So definitions will have to be modified and adjusted, but this is left to the future to suggest. The only indication is that if you have chronic kidney disease, stage 3, you can start treatment at a level of 9, but there is no figure above which we start treating hyperuricemia if it is asymptomatic.
Okay, thank you, Dr. Gafar. The question for Dr. Adham, radiological manifestation take 10 years to appear. How CT and musculoskeletal ultrasound shorten this period?
Well, I've showed that if you use ultrasound, and of course, if the patient has the access to specific type of CT, the DECT, this can actually inform about the amount of crystal deposition and the inflammation surrounding those crystals. So probably those missed attacks of inflammation can be pre-diagnosed. But more peculiar, that you know that the acute gouty attacks, especially in the beginning, are short-lived, maybe with some treatment and sometimes even without treatment. So if you see the patient after, I mean the patient coming to you saying, I have no findings now, but I had inflammation, probably clinically you have to take a good history and examination, but it cannot help so much. You have to have a doubt on what is recurrent or what is palindromic. With the ultrasound, maybe you can detect hyperuricemia, you can detect crystal deposition, you can see double contour, these are all in the favoring gout, while in absence of acute inflammation. So they can make your life easy to diagnose and detect before years go by.
Okay, thank you, Dr. Adham. Another question. Sometimes it is difficult to differentiate between snowstorm appearance and the aggregates. If the size is the only difference between it, and why snowstorm is considered non-specific.
Not only the size. The size can make a difference between aggregates, tophi, and macrotophi. It's all crystal deposition. For the snowstorm, it's not all crystal. There is crystal aggregates in the middle of synovial fluid. So if you press with a probe, you can imitate like a snowstorm, moving things with hyperechoic dots. It's not the size. The presence of these dots, the dots is not a single crystal. When you see a dot with the ultrasound, that means one dot is crystal aggregate. So dots moving means that those crystal aggregates are in the middle of synovial effusion. But the difference in the size would differentiate this from size and structure, of course, the tophus and microtophus, for example. Second question, why snowstorm is not peculiar to gout? Because this appearance of fluid that has hyperechoic dots inside can be seen in so many diseases. For example, if you have osteoarthritis with some bone debris inside the effusion of the joint, it can give you something like similar to snowstorm. If you have a patient that had an injectate, for example, steroid with crystalline material, it can look like a gout. For example, if you have a patient with folding synovium with the specific angle of insonation from the ultrasound over the angles of the synovium, it can give shiny appearance. So all these can look, especially to the beginner or intermediate level sonographer, they can all look like snowstorm or shiny particles. Please don't go quickly to diagnosing fluid with shiny particles, saying those are crystals. Not necessary.
Thank you, Dr. Adam. The question now for Dr. Gafar. Please, Dr. Gafar, please explain more about the management of gout on top of rheumatoid arthritis. And more emphasis, please, about what was meant by reducing level of uric acid. In this case, will aggravate rheumatoid arthritis.
I meant to put my slide on the benefits of uric acid. Uric acid is a strong antioxidant. It's believed that it was the price that the human race of the Homo sapiens had to pay for longevity, because when you grow older, you have more particles left and in the body, and you need something to protect the cells and protect the DNA from these free radicals. So uric acid had to be increased to allow for this longevity. It's said that it's a trade-off for longevity in our race. So uric acid is not altogether harmful. It has some benefits, as I mentioned before. The definition or the entity of tumescent gout meant or means the combination of RA and gout in one patient. It was observed earlier that before having treatment, which is very effective for rheumatoid, we used to see that whenever you attempt to lower the uric acid vigorously, you had a flare of the RA. You had a flare of the arthritis, paradoxically. But now we have better drugs to manage RA. So we can manage both effectively. But earlier we did not used to see that. One of my friends in a pediatric rheumatology department said, we used to see patients coming on wheelchair with the introduction of methotrexate in the late 80s and the early 90s. We started to see them coming assisted with a cane or whatever. And with the introduction of the biologic drugs or the biological era, they come on foot walking normally. So the effectiveness of current treatment does not allow us to see this. What I meant to say is that uric acid should be lowered, but I meant to explain that uric acid is not altogether harmful.
Okay. Thank you, Dr. Gafar. Another question for Dr. Gafar. Do you have any recommendations that is easily applicable in practice for patients with recurrent attacks of gout and still complaining, however, on the patient is in maximum dose of uricosuric drug and the urate lowering drug?
What do you mean by maximum? Are you sure that you reach the maximum? For example, make sure that the patient is receiving the maximum drug as defined. Allopurinol, for example, allowed till 800. If you do not reach this level with titration or with drug dose escalation, you are not reaching the maximum. And if after this you added something more like urate lowering drug or whatever, that's another point. If so, you'll have to go for a stronger medication if accessible in your country. Okay. We have a limited access to interleukin-1 antagonists, the anakinra or kynurenine, but it's available at a very costly price here in Egypt. But perhaps it's available so in other countries more easier.
Thanks a lot, Dr. Gafar. The question now for Dr. Adham.
Another point, excuse me, make sure that the patient is adhering correctly. The point of adherence to the treatment is very important. It's not enough to write the prescription, to write the exact dose, and to see if the patient is not responding. You have to check that he's adhering. This is a common problem that we see with other medications as well. Adherence is important, and you should make sure that the patient is compliant. Okay. And motivated and educated. That's why the paramedics were introduced or brought into helping the doctors in teaching, educating patients, following them, talking to them. It's essential to have this approach.
Okay. Thank you, Dr. Gafar. The question for Dr. Adham, is the double contour disappear after treatment?
Yes, it will disappear after treatment, and this is very nice finding for follow-up patients, mostly in about 7 months.
Okay. Another question is a double contour must be present in medial, lateral, and intercondylar area at the same time, or can be present in any of them?
Can be present in any of them, but professionally speaking, you can detect it despite the angle that you are looking, because this is the position over the cartilage, and the cartilage is 3D. So if you move the probe medial and lateral, you can see it, just like the erosion. But it will depend on how professional the sonographer.
Okay, thank you, Dr. Adam. What's the difference between double contour and the interface?
The interface is on the perpendicular part of the ultrasound, is a normal finding, and can be only in the upper part linear. It does not go with the round part of the metacarpal or metatarsal head, and usually is very thin, and can be augmented, either present normally or augmented by the presence of effusion. The double contour is thicker, and it moves when you do a dynamic examination. It will move with the cartilage because it's a physical deposition of the crystals, and usually it will go to the rounded part of the metacarpal or metatarsal head cartilage, and usually is thick as the bone line, and that's why it's called double contour.
Okay, thank you, Dr. Adam. Another question for you. Do you recommend scanning patients with very high level of uric acid in asymptomatic patient?
Well, if you scan them, you can find findings of asymptomatic hyperuricemia, just like the double contour or crystal deposition. But if the patient is complaining, then you are searching for tophi, synovitis, more specific findings that say that the patient is inflamed. If for your own interest you want to check asymptomatic hyperuricemia patients, you can still see findings. But like Professor Ragab said, it might not be relevant to your treatment.
Okay, thank you. Another question, is it easy to differentiate between psoriatic arthritis and gout by ultrasound regarding erosion and other finding, other than tophi?
It is not by the elemental lesions. That's what I explained in the beginning. When we first learn the ultrasound, we want to say erosion, osteophyte, synovitis. After that, you have to combine the more complex of these findings, more elemental lesions together with the history and examination. Don't forget that you have sat with the patient, asked questions, took some history, did some exam, and then add. For example, is it monoarticular, polyarticular? Is it polyarticular? Is it bilateral symmetrical? Do you have any skin manifestations? Do you have to find? What are the findings that you can see? In a lot of psoriatic patients, you can find accidental hyperuricemia, or not accidental, concomitant hyperuricemia. So maybe you want to detect, is this chronic tophaceous gout, or this is hyperuricemia associated with a seronegative disease? So if you find tophi and the sequelae of damage in the joints, then you're talking about a long-standing gouty disease. If you see more of tendons, erosions, and the ECU sparing the wrist, taking the distribution of the psoriatic in the hand, and nail psoriasis, enthesitis, and detecting your enthesitis to see if there is an inflammation, then this goes with the psoriatic. It's usually a combination that you want to see, and indeed with ultrasound, you can really give upper weight to one over the other.
Okay, thank you, Dr. Adham. The question for my professor, Dr. Gafar. What about hyperuricemia and psoriatic arthritis? Is there any recommendation?
We talked about the comorbidities. Usually we check for comorbidities with gout, and with psoriasis. Psoriasis can be associated with some other components of the metabolic syndrome, and you may be met with uric acid elevations in serum uric acid, hyperuricemia, I mean. So you have to tackle each problem individually, and you have to manage both.
Okay. Are you preferred to give urate lowering drugs in acute attacks or not?
I mentioned this point of contradiction between our practice, European practice, and the American. The point that the Americans raised was that they prefer to give the urate lowering drug during the attack, because the system there is that you visit your doctor during this period. If you are bound to have a repeated attack if you do not stick to the urate lowering drug. They are afraid that the patient might lose the motivation, and by the time he goes to the doctor for follow-up, he may have lost interest altogether. So they said, go ahead and start it. And the evidence for deferring or delaying the onset of urate lowering drug is not that strong. But actually, I would not. I would ask the patient, insist upon the patient, and contact him to ask him after the subsidence of the attack to come back, and we can then start the rate lowering drug. Usually, as Dr. Adham mentioned, usually the first attack does not last long. It may be it may end spontaneously within days or weeks or whatever. So it's not a big deal to ask your secretary and yourself to contact the patient and insist upon seeing him, and then you can start the medication. But I don't know the American system, but I would not do that. I just mentioned what they prefer, and actually it's a condition recommendation.
Okay, thank you, Dr. Gafar. The question for Dr. Adham. Do you recommend routine scanning for CPD in with osteoarthritis instead of what is usually done in practice, and to aspirate and inject steroid?
I do personally. I do scan for CPPD because it's easy. You can check 2 or 3 places like the triangular fibrocartilage, the knee, whether the articular cartilage or the anterior horn of the medial meniscus. I do this routine for older patients with osteoarthritis, especially if not resolving. To inject, if it's a CPPD, the injection can help. And also, if it's inflammatory osteo, it can help. So injecting steroid is okay, yeah.
Okay, thank you, Dr. Adham. Another question, can double contour sign persist despite effective treatment?
No, it will disappear. This is a reversible phenomenon and usually disappears within 7 months.
Okay, how can
let me say that studies showed that if uric acid is above 6, this will not happen. So we have to control the uric acid below 6. It will disappear in 7 months.
Okay, thank you.
How can I add a point to Dr. Adham? I remember during our last EGYSIR, Dr. Bardan said during his talk, the title was a curable disease that is seldom cured, because we do not treat to target, we do not lower the uric acid to below the threshold that we mentioned before. So before saying that the patient received treatment, you have to make sure that he is targeting the treatment, his physician is targeting the treatment, he's complying, he's adhering to medication, and that you are following him regularly.
Okay, thank you. Question for Dr. Adam, how can ultrasound differentiate between tophus and subcutaneous nodules?
I didn't want to put this because it's much more difficult of a differential diagnosis than any other finding. Usually the sites of the rheumatoid nodules are more specific than the gouty ones, but also the composition and the structure, the echogenicity is more homogeneous for the rheumatoid nodule. And it can range from the soft material in the beginning till the hard, usually related to bone surface, but the Doppler and hyperechogenicity are seldom seen.
Okay, thank you, Adam. The question, role of musculoskeletal ultrasound in differentiating suspecting gout on top of RA.
Say again, please.
Role of musculoskeletal ultrasound in differentiating gout on top of rheumatoid arthritis.
This is tumescent gout. I mean, everyone wants to use the ultrasound as the only way to diagnose the disease. You cannot do this. Tumescent gout, like Professor Ragab explained, can make the joint of gout swollen like RA, and you have to detect the specific findings related to each. Some would be non-specific if you have normal synovitis, and some would be specific. In the rheumatoid would be the rheumatoid erosions in the specific sites, the specific joints. For the gout, it would be the type of erosions and double contour and so forth. It's actually very interesting using the ultrasound when you have both, because you can tell your doctor or the referring physician which entity is taking the upper part, the upper hand, but don't depend only on the ultrasound.
Okay, thank you. Do you recommend delaying ultrasound after intra-articular injection?
Delaying ultrasound?
أعتقد تقصد حاجة خلاف other than musculoskeletal ultrasound.
Perhaps the question is raised because of the point of the confusion in diagnosing after the crystal forming the steroids in the injection.
Okay. You mean if you injected or a joint, maybe at least 2 to 4 weeks later, you can still detect the snowstorm appearance by ultrasound. However, it does not forbid you from doing the ultrasound for the other joints or something, or for the same joint. Because if you inject, synovitis and acute inflammation is going to improve, but you can only have some fluid with the snowstorm. So neglect the snowstorm appearance because of the injectate and comment on the other findings. That's if what he or she is asking about diagnostic ultrasound. If he or she is asking about some physiotherapy modality ultrasound, it is recommended to stop for 2 weeks at least after the injection.
Okay, thank you. What about detecting gout activity in case of gout on top of erosive osteoarthritis by ultrasound?
Erosive osteoarthritis is not so common as gout, and not so common modality in the osteoarthritis itself. It would be very difficult because this is usually in older age people, and those people can get erosive changes, and the gout signs might be manifesting. So if you are trying to check the difference in the erosions, always the gouty erosions are so different from most of the other erosions. You would only have to add the distribution of the findings, the clinical history and complaint. But for the specific erosions, the wide boundary, well-demarcated big erosions that are seen in specific gouty joints can differentiate. I wouldn't say all the time, but it can happen.
Okay, thank you. What's the difference between hypoechoic and hyperechoic tophi? It is a matter of chronicity or not?
Say again?
The difference between hypoechoic and hyperechoic tophi, if it is a matter of chronicity or not?
By definition, the tophi would not be just hypoechoic. They should be inhomogeneous, and usually they are a mix of hypo and hyperechoic because it's basically has some crystal aggregates. So it cannot be completely hypoechoic. Sometimes we see it, but this is usually with treatment. But if you see the tophi classically, they should be inhomogeneous with hyperechoic spots. If hypoechoic, then it could be with anechoic rim and could be with the skin manifestations or the history, very suggestive. But if you are in doubt and seeing the tophi in undiagnosed patients, then it would be the one with heterogeneous material and shiny particles.
Okay, thank you, Dr. Adham. The question for Professor Dr. Gafar. When a patient has asymptomatic hyperuricemia with high level more than 11, but associated with other comorbidity like psoriatic arthritis and other features of metabolic syndrome, do you recommend the treatment?
In principle, we do not, but always treatment should be individualized. You have to check your patient. Is he having a renal disease? Is there any other problem like whatever?
Okay,
In
thank
principle,
you.
we do not treat asymptomatic hyperuricemia. The only recommendation is for some chronic kidney disease at a certain level that we mentioned before, and if it is above 9. But in principle, no.
Okay, thank you, Dr. Gafar. The question
Treatment should be individualized.
Okay. Thank you, Dr. Gafar. The question for Dr. Adham in this case, is ultrasound show evidence of uric acid crystal deposition in case of asymptomatic hyperuricemia more than 11 and associated with comorbidity, psoriatic or metabolic syndrome? Is the ultrasound show evidence of uric acid crystal deposition?
The ultrasound will show evidence of asymptomatic hyperuricemia, whether as a standalone situation or in combination with any other disease.
Will it differ in treatment or still won't give any treatment?
The treatment would be if we have a comorbidity for the other medicine, for the other disease, because as Professor Ragab said, we don't usually treat asymptomatic hyperuricemia unless the patient has very high uric acid or compromised kidney functions of older age or glomerular filtration rate is reduced. There is very specific points to look at which level to treat and in which chronic conditions that the patient or the age maybe, the kidney situation, but usually we don't treat asymptomatic hyperuricemia.
Okay, thank you. Another question, Dr. Adham. Tendon tophus versus heterogeneous mass. What is the difference? Tendon to phi versus heterogeneous mass.
Heterogeneous mass, meaning something like a tumor, giant cell tumor, would be localized to the tumor. But to see a tophus in the tendon or in the tendon sheath, then we have to comply with the entity of Tenocynovitis, inflammation of the tendon and the tendon sheath with effusion, hypertrophy, crystal aggregates, and the tophi. The heterogeneous mass is just a localized mass without necessarily all these findings. This is the only thing I can tell you.
Okay, thank you. Another question: if I want to inject in case of monoarticular, how to differentiate if it is septic arthritis or no?
It is very, very difficult and challenging to say septic arthritis using ultrasound. This is clinical and history suspected, and you can only confirm few findings with the ultrasound. Of course, if the direction is sudden swelling of a joint with hotness, redness, pain, by ultrasound there is effusion, snowstorm, double contour, then we are moving towards the gout. If we don't have this and it's only non-specific synovitis or complicated heterogeneous synovitis with Doppler without any finding of hyperuricemia, and you have a doubt from the history, then don't inject steroids. Of course, you're supposed to aspirate and probably see the type of aspiration and if it's pus or something or infected.
Thank you, Professor Dr. Gaffer and Dr. Adham for discussion. There is no more questions up till now.
Thank you.
Thank you
There
very
is
much.
a request for text the book link for ultrasound.
I can show you some books. This is a musculoskeletal atlas of ultrasound. This is John Jacobson's one. It's very, very nice for people with intermediate level. John Jacobson is a very known radiologist from the States. This is the book I participated in, one of them. This book is by the Euler. It's for the good disease by the joints. This is a Euler book, but I don't recommend. It's very concise and lacking a lot of information. For the advanced level, I would recommend Martinoli. Martinoli book is so big and so complicated, but Martinoli is really, really an expert of ultrasound that no one is like. So when you are advanced with ultrasound, get Martinoli.
Okay, thank you.
Thank you.
Okay, so we are done with the questions.
All questions or answered.
Thank you very much. I would like to thank Professor Iman Fikri for helping organizing and marketing the events and moderating tonight's session. All the thanks to Professor Ghaffar Ragab for his very, very precious time and luxury of information that he gave us tonight, and his patience for all the questions and pushing the ultrasound school and the society. Also our greetings to Professor Muhammad Salah and all the professors that participated in the previous sessions. We will think if we extend those sessions once more to cover more subjects. I think it was a very successful and peculiar because of the speaking professors. All the best to all of you, and thanks to Amgen and Iris and to EGYSIR, and hopefully to see you soon again.
Thank you.
Good night, everyone. شكرا دكتور غافر، شكرا دكتورة إيمان، شكرا إيريس.
شكرا لكم جميعا، وشكرا لاستضافتي، وكان يوم جميل. شكرا.
شكرا جزيلا. شكرا.
شكرا لحضراتكم.